I need you here. So thank you both for your presentations, which certainly will stimulate a number of questions, I'm sure, both from the roundtable and the audience. So I'm going to ask the roundtable members who have questions to please come up first, so we can ask the questions from the roundtable, and then the public obviously follow thereon. Don't everybody jump at once, but Alicia, I see you're on your way up, so I'll let you start. Alicia.
Thank you. Alicia Fernandez from UCSF, San Francisco General. I have a question for each of you. My question for you first is about default enrollment. I'm a big fan of default enrollment for all sorts of issues, such as pension plans, and so on. And I am wondering to what extent you've seen discussions about this, and to both among stakeholders and particularly among the insurance community. And my second question, I hope that this isn't too bothersome, has to do with this issue of what navigator assistants in Missouri are allowed to do or not allowed to do in terms of explaining to people their health care rights, particularly as it relates to language interpreter services. Because for many people, this is the first. This enrollment process can be the first time in which they're face-to-face with someone outside of the safety net systems. Thank you both.
I'm going to start. Thank you for the question, because I forgot to call that out in the slide about the default choice. It is a way to help people. How much it helps people depends on how it's done. I know that there are some Medicaid plans that when people do not make a choice, they default into. But how they do that, whether they just do a rotating sort of spin the wheel, or if they look at the characteristics of the individual and their needs and make a choice for them, that would be the preferable. I suspect that most of the default choices are of the first sort.
Has there been much discussion? Are you aware? I'm sorry. Are you aware of whether there's been discussion in the commercial among the commercial insurance and the commercial plans about having a default, or maybe even one default plan per insurer, like a silver plan for everyone, unless you go up or down?
Yeah, I don't know that, but it would be worth exploring. I agree.
Katina?
So the second part of the question was about how much navigators were allowed to explain language interpreter services, other things like that. And I'm going to make sure that my friend Dara Taylor checks me on the policy and technical rule here, because I actually don't spend any time on that, because that's what Dara's contract focuses on. What I can tell you is that we've created supports for that. So one of our videos talks about how to talk with interpreters, and there are materials. We also, in the early part of our health insurance literacy work, had a subcontract with the International Institute of St. Louis, which is a provider in St. Louis that works with refugee and resettlement communities in our area, and through that relationships, we were able to translate most of our materials into, I think, about 9 languages. So we're able to support the translation of all those materials, and also then connect folks with the International Institute folks who then provided resource. And so they had a lot of the materials available for use, and then their workers were going out and doing it in multiple languages. And so I feel pretty confident, despite outside the technical kind of rule, that people were having conversations about what to do and how to do, and they were doing it in many languages, but I'm not sure about the technicality. Dara, do you know anything more?
It's not required that they share that information, but the majority of them do, and it's been just encouraged for them to do so.
Thanks.
Winston?
Hello, Winston Wong, Kaiser Permanente and a member of the Roundtable on Health Literacy. So I appreciate Dr. Hibbard's studies, but I think there's actually a question that comes before the question of how people make choices, and it's a question of how people establish value in terms of trying to even put the choice in front of them, which brings me to the heart of the question, which is more directed at Katina. And you kind of touched upon this, and as I recall, Missouri is a show-me state, right?
Show me.
Yeah. It has to do with the aspect of how health literacy plays out in a state that's a non-expansion state, and whether there is subtle or real differences in terms of how health literacy is able to convey aspects of the evidence, which is people are going to be healthier if they have access and insurance, against the backdrop of culture, which you touched upon in terms of it's my right to decide whether or not whether I have health insurance. And then, of course, the politics of the dominant political stream of thought in a particular state in terms of whether health insurance coverage is considered Obamacare and a political agenda. I think this is really critical in terms of understanding the interplay between these different aspects and how health literacy gets expressed within that context.
So I couldn't agree more, and I think that's how we ended up with the community approach at the end, because there's a lot of variability across a state, even a state within the state that's the STOMI state, and all the things that you just said. As we went across the state, we found that every place we went, there were kind of nuances. And so that idea of being responsive in our communication to the needs of that community and starting, like you would with any other issue, where people want to start, and framing that issue in terms of their value and what was important to them really made a difference. And so I appreciate the offense statement earlier when Michael Pachorlo made the comment about the displacement of social workers and other folks. I'm a social worker by training. That's where we start every conversation, every activity, is this idea of what's important to you and what's your value, and how do we go from here to where we want you to be, where we think you should be, knowing that along the way we might have to adjust because you know more about you than me. So I have to be open to that. And how do we kind of have conversations that are one-on-one, but also reflect the community and what it means to a community when a whole bunch of folks decide they're not going to do something that then affects the hospital, for example. So really deep level conversations that take everybody, as you know. I think that's part of what you said. So did I answer at least that I care about that?
I think you did, and I'd be very interested actually in terms of later on today for those states that are so-called expansion states, whether there is any kind of documented difference with regards to the utility of health literacy relative to how a state takes on ACA.
That'd be really interesting. Thank you.
Linda?
Hi, I'm Linda Harris. I'm from the Department of Health and Human Services in the Office of Disease Prevention and Health Promotion. And I have a question for both of you related to prevention. Part of our task is to inform the public about the preventive services they need. And we're finding that a lot of the attention about the ACA is really about coverage, and that's such a hard problem that sometimes we don't get to the part of, well, what about encouraging people to get those free services? And so both of you, I think, have done some work that might be informative on that front. Your work in Health Literacy Missouri, I know a little bit about that. I'd love to hear more, kind of a drill down on some of the videos. How did you formulate them, and how are you helping people not only make decisions about the preventive services they need, but at that, which ones do I need? But within services, there are a lot of complexities about making those decisions, and we're working right now with providers to help them kind of figure out, well, how do you make a decision if the evidence is not clear? And so my question to you, Judith, is about work you've done on kind of decision-making, and you talked about coverage, but have you also done some work, do you have some thoughts about how those principles might be applied to the work that we're trying to do on helping people understand, in our case it's preventive services, but it could be any kind of services and the complexities involved in those choices?
So, it's a complicated question. So, thinking in terms of all the work that we've done, the strategies are kind of layered on top of each other, and there are strategies for the navigators and for consumers, and the videos really cross both of those populations for a lot of reasons. One, they're often the same people, but two, the navigators and the assisters were the people that community members kept going back to again and again. So what we found is once they got their coverage, they would go back and say, okay, now I'm going to go to the doctor, and do I get this prevention visit, and what do I ask for, and how do I do it? Because that was the trusted person. And so kind of situating the knowledge with those people was really important because it reinforced what's next and how do we do this, to get them to the place where they could talk with the provider and ask a real question to a person who's hopefully ready to answer it. And in Missouri, we've done a lot of work with providers on health literacy to be able to talk back to people about what the options are and what's available and what the resources are. But like everybody everywhere else, I think it's mixed results on who does that. It's pretty provider specific. And the providers have been not that involved, I would say, in this work, unfortunately. So we get a lot of organizational level involvement. So people in health systems that got Navigator grants are very involved, and those folks know how to have those conversations. But if you're not actually a provider in one of those systems, the conversations, I think, look a lot different. At least they do in Missouri. So I don't think the rest of those providers are active. They're not pointing toward this. And for us, they're connected with big systems, too, who have been, there's some political issues about what it means to get these folks in the systems. And so we're still really struggling with who's going to serve who, depending on the level of coverage. And so those messages about prevention, I think for us have still been answered kind of face-to-face by a person who is a community health worker, an assister, a navigator, a person that helped you get your coverage in the first place, your friend or neighbor, someone that you know. There's stuff online, resources like that, but it's all this kind of personal one-on-one direction to get you to the place where you use and practice and kind of reinforce the skill, best I can tell. I'm not sure if other people have different experiences, but that's what we're hearing.
So getting people's attention on the prevention issue it's clear that that's a big one, that people don't know that the coverage is first dollar on the preventive services. And ways to counteract that is to highlight that information in communications about signing up and about the coverage, and also highlight it in how to use your coverage. I think the issue that you brought up about the ambiguity, we know that when people think there is ambiguity about an issue or about information, they're just less likely to pay attention. They're less likely to act on it. So some of that could maybe thinking about tailoring the information to certain groups and using different media to target them. But all of those are make it much more complex to get people to act when there is ambiguity about what the right thing to do is.
And just one more comment. I think, we're also seeing that we don't necessarily, that the word preventive care visit, prevention, is not a word that people are also processing. So they don't know what that visit is supposed to be and why you would go. So the idea to get people to just do a thing, even if it's going to be free, is connected to like this other stuff that you had to do that was maybe not so fun, like, pap smears and mammograms. And there's all this stuff that you don't want to do, and shots and stuff. And I don't think people get the concept of what this is and how it works. And so how do we get them to do a thing that's, consciously connected to something bad that we don't understand any differently? And we think also we've heard stories that there are also the prevention visit changes to be a different visit, and so then it ends up costing money. And those kind of horror stories are out there a lot, and so how do we kind of undo that narrative as well? Or if it's happening, how do we help providers understand that if you go for a preventive visit, it's got to be a preventive visit, and you need them to come back for something else, that's got to be something else. That was not happening in Missouri at all. People were going and they were getting kind of bait and switched a little bit. And I don't think it's intentional. It's just the way medicine maybe works. We've got you here and you're captive and we need to deal with all this stuff. But when the visit you thought you had for free ends up costing you $30 and that was your food money for the week, that's a problem.
Maren?
Hi, I'm Maren Allen. I'm with NIH and I'm on the roundtable. And my comment question is for Dr. Hibbard. The notion of nudging is something that we're always comfortable with if we're doing the nudging, or the good guys are doing the nudging. And one of the concerns that I have, and it goes back to some of the language in the Affordable Care Act, that our role is really supposed to help people make the best decisions themselves in a continuing understanding of their interaction with the health system. And I'm just concerned that when we leap to nudging and other folks who may not be on the same side of the panel move to nudging, we're taking away some of the freedom of that individual to choose rather than simply giving them the options. And when we overly rate, for example, hospital self-evaluations of whether or not people had a good experience, well, did they live or die? I mean, there's a lot of differential in the amount of information that's being provided in those forms. So I'm just concerned that we need to teach people also how to adapt to change. Because when you're sitting in that situation one-on-one, face-to-face with the navigator, that's the last time probably you'll see that person. 5 years from then, they'll be living in Montevideo, and you'll be living whatever that navigator helped you choose. And there's so much change that goes on in the system, helping people determine how to see when change is happening. So that's just kind of a comment, and I'm sure it's something you've thought about. So
Yes, and that's why I said that all of these takes more responsibility on the part of the information provider. If you are trying to counteract decision errors. But there's one other point that I think is very important here, and that is there's no such thing as an objective data display or comparative display. Whatever we do, we are influencing people. Most of the time we don't know how that data display or that way we're comparing things is influencing people. Isn't it better to know and to do it in an informed way than to do it in a way that you have no idea how it's influencing people?
And I don't think this changes your question at all, Maren, but I do want to make the point that, at least for us, we heard that it's not the last time they see each other. People were going back monthly in Missouri to ask their navigator or a sister to help them pay their bill because their level of confidence that the insurance company would get their bill and count it was that low. So they were very worried that if they did that on their own, even with a confirmation number, it wouldn't be counted and their plan would be canceled and they couldn't get a new plan until open enrollment. So they needed the assister to be the person who did the mailing, the phone call, the credit card payment, wrote down the number with them, recorded it and kept it, and they go back and do that over and over again. So, I mean, I understand your point that they don't see them again, but these folks, this idea of coalitions and people and trusted sources, I think is something we really have to think seriously about, whether they're navigators, assisters, community health workers. Folks aren't giving this up easily. They really cling to that lifeline.
And it sounds as if the situation in Missouri is different from some of the larger cities and in some of the rural areas in terms of that. That's something we probably don't know yet, but the assumption would be that larger numbers of people, you're not going to get that same kind of return.
So speaking about nudging, if there are any individuals from the non-roundtable members who want to come to the microphone, I think I have time for one or two, seeing who's at the microphone now. Michael?
Hi, Michael Pashor, the Boston Medical Center again. So I usually resist the balkanization of literacy concepts, you know, fashion literacy, insurance literacy. Everything's got its own label, right? But here, there's such an interconnection between numeracy and financial literacy. You know, so this other concept that now comes up that I wanted to see if you guys could talk a little bit about. And so financial things like avoiding financial catastrophe, avoiding personal bankruptcy, you know, where our health sector is the leading cause of personal bankruptcy in the United States still. But hopefully that can change because of this whole movement that you guys are all working on, which is fabulous. See, I said a positive thing.
There you go. That coffee break was worth it.
I wanted to just see about how the financial literacy plays out in terms of training and in terms of all this stuff. It certainly looks like a financial activity in that respect. And especially for people who live in a HPSA, as many people do, a health physician shortage area, it's not really so much about getting that preventive care, because that's a 2-hour drive anyway. It's really about avoiding financial disaster in emergency care. So I don't know if you want to comment about this.
So that's what so many of our tools really work on, is kind of what's the cost, what are your conditions, how do we work through the series of choices to help you weigh that option and make a decision about what you need and how that works. The education about kind of this disaster thing, we don't go to because there are reasons to do that, and there are certainly reasons not to. We start from a place of kind of positive. You want information. This is the kind of information. This is the information you need to make the choice, and how do we walk through this? So what are your health conditions? What medicines do you take? How many times do you go a year? How many kids do you have? What kinds of things do they need? Blah, blah, blah. You can kind of script that out and help people work through the finances and think then on the other side of that, what money do you have available, and help them kind of make an informed choice about that. And the navigators and assisters do that really well if they have tools. And people make choices really easily. If you're really, really poor, I think a lot of people know this, you think really carefully about what you do with your money. So if you can lay that out with them and help them not miss any of the kind of big bucket items, folks can do that and move toward a good choice. But again, if you make the choice not to, and something really bad happens to you, catastrophic, that's a significant risk, and how to talk to people about weighing that risk, which is so unlikely, but if it happens, it's so terrible, is a really big conversation. Absolutely.
Ruth?
So I really want to hear Judith answer that as well. Oh, Ruth Parker. So it's quite a follow-up to what Michael was saying, but I was really thinking about how we operationalize affordability, which still is on the forefront with the Affordable Care Act. How do you really take affordability and make that a concept that is part of your choice? And I know in the commission work that Kavita and I worked on with Lila and some others here, where we looked at early successes and what we found, the whole idea of talking with people and trying to help them with decisions that really do center around whether or not you can afford something, despite it being the law and all that. So I'm wondering, just from a data standpoint, if within the evidence that you've given us, Judith, that helps us think about deconstructing what the tasks are, how we make that in an evidence-based way, moving toward taking the burden the burden to be on the information provider, and that being something that becomes more navigable. Do we approach that any differently when the issue of affordability is front and center in the minds of people? Do we know anything from an evidence standpoint about how we do that for people who are having trouble deciding whether or not they can even afford it, sort of, the approach of that? And I think, Katina, you gave us some great examples off the ground of what you all have done, but I was really curious about data-driven.
Yeah, I think those principles can be used. And as you were talking, I was thinking about, so if we knew something about the decision maker, about their income, about their health status, their history with using health care, you could identify most affordable plans for that individual, and you could order it or you could call it out. But I think people would really appreciate that, because part of the difficulty that people face when they're looking at such complex information, so overwhelmed by the amount of things that they need to consider, is to help them think about what should they be thinking about, and even to start the process with what are the most important things to consider here. So sort of walk them through the decision process. And you can say affordability is one of the key things that you should be thinking about. And then if you want to order these plans on affordability, here's how you do it. That would help.
So we have 3 speakers at the microphone, and we'll finish with the 3 speakers. I'll take 2 from the audience, and then Alicia.
Hi, Eric Elzers from Consumers Checkbook. I want to follow up on the point that Winston made about value and add that people make complex choices that involve value weights a lot. They choose apartments, they choose cars, things of the same scale. And it seems like part of what they're doing in their day is assimilating price information so that they can make those trade-offs. So I think that we're in this moment of learning, and I wanted to know what you all think can accelerate people's ability to take that in. They just don't see price trade-offs in insurance choice enough to have any mental background for it. So what can they do to start getting that and building their own set of knowledge about what I should pay for something and what the... No, I don't have an answer. What can we do to get people be able to take more of that information in and build their own mental database?
Yeah, I think that we need to sort of work on both the end of, okay, what should I be considering here? Help them understand the highest priority things they should be considering, and then present the information in a way that it's processable. Like less is more. Less information that's summarized. Instead of at the top level giving all of the cost information, let's give them estimated yearly cost and premium. They can probably make a good decision based on those 2 things. We can always provide more information at a deeper level, but when we overwhelm people with too much information, it all gets lost.
Can I just say something about this point?
I have other speakers, so if I have time, I'll bring you back. Yes.
I just wanted to thank you for your presentations and your work. I'm a big fangirl of everything you said, pretty much. For you, Katina, I have one question, and for you, I have another question. In your community coalition, which I think is awesome, did you include church, Walmart, and frontline clinical workers as part of that community?
Yes. So Walmart, not specifically. Church, yes. Frontline clinical workers, yes. But
okay.
yeah, so
yeah, Walmart's doing a National Health Day where
Yeah.
they're immunizing and they're trying to do interesting stuff. So it's an interesting yet kind of semi off-putting thing to consider. But
a cool idea though, and we're just starting. So it's not that Walmart can't be included. It's just the idea that all of this is kind of driven in a responsive design. So writing it down.
okay, yeah. Sometimes they're the only show in town, so it could be helpful. And for you, Dr. Hibbard, thank you for your research. I think it's phenomenal. And some people pointed out. How, if your drug is off formulary, that's going to affect your pocketbook. Or if you have 4 people in your family and the deductibles add up, but your family's healthy, then the premium, matters more. And I wonder if you've done any research around scenario modeling. So helping people envision your family, if everybody remains healthy, this will be what happens. Your family, if somebody breaks their leg, this will be what happens. Your family, if God forbid someone gets cancer or has a heart attack, this is what will happen. So scenario modeling and doing research around that, have you done it? And if not, let's do some together.
Did you want to respond?
Sorry. I have not, but I think it's a productive direction. Yes.
Alicia?
I wanted to defer to Dr. Benjamin, or Ms. Benjamin, sorry. and because I have a feeling we're about to disagree, or and I think it's really
in that time period, you could have asked your question.
But I think it's really important to get these two views out, because they model different ways that I think the roundtable needs to really struggle with. So please.
Well, I was just going to say it's not like buying a car or an apartment. It's so much more, so much hard. Look at all the moving pieces. You have, what other decisions? You have co-pays, premiums, deductibles, co-insurance, maximum out-of-pocket, networks, HMO versus PPO, and we haven't even started with the tax credits, financial penalty if you don't do it at all. I mean, there are so many moving pieces. The only answer to health literacy in this area is to actually simplify the whole system. Like, we have to simplify insurance. It's not fair to put this on the consumers. I mean, I'm sorry, I know, I mean, like, I sound like, I don't know who, but anyway, you can have your time.
We completely agree. But where I want to come back to is the assistance and the point that I want to come back to, the point about nudges and automatic enrollment, particularly when dealing with rare events. And for most people, being ill, fortunately, I'm an internist, but for most people, being catastrophically ill is still a rare event. And and the example I'll use is my first job as a faculty member, where I was told, "Oh, you're going to get stuff deducted for your pension. Where do you want to put it?" And I was like, "I don't know." And the person said, "Well, you have savings. You have this. You have this. You have that." And I said, "Oh, I don't know. I know savings. Savings sounds good." So I did savings and missed the entire run-up of the stock market in the 2000s. I come from a working class background with a family with poor financial literacy. If I worked for a company that now does automatic enrollment into a standard pension option, I could then choose to educate myself and go for this one or that one or that one, but at least I would have been in. That is using with people's monies, and the IRS now permits small businesses to do automatic enrollment with a series of safeguards. I really think that I thought we had gone beyond trying to work on the let's teach people how to read and write better to let's teach the system to work better for people. So I don't understand. I'm not saying not to have assistance and 90 minutes per person to work on those particular folks with chronic illnesses and a whole set of conditions. What I don't understand is why we can't think through the issue. What I would like to encourage us to do is to think through the range of issues from nudges to automatic enrollment that would protect people and allow them to, from there, be able to make better choices that would be optimal for their situation.
Can I put an asterisk by this discussion? Because it's not really one system. So when we talk about dismantling systems, we're talking about health insurance and health care. So I don't know how we dismantle both of those simultaneously.
You could do one.
What?
Sorry.
Yeah, so both of those simultaneously. So, I mean, I think that that's a productive conversation to talk about what happens when you have a new system. But part of the Affordable Care Act was to kind of redo this system. And I just want to say, I think so the question about Consumer's Checkbook, what do we do? I think we're doing it in kind of slow steps. How do we move people forward? Even if there's a completely different system of enrolling and doing all this stuff, people still have to know how to take care of themselves. They still have to learn how to use it. They still have to know to notice a symptom and show up and do a thing. So this is kind of the layering of health literacy, health insurance literacy, and I don't think that we can oversimplify that and kind of diminish the idea that this is stuff that we're going to have to grapple with.
Cindy, last comment.
We've had a lot of conversation in this session about not choosing plans just based on premium, but there's still this underlying assumption that it is money that is driving us, that if you can know how many of which services you're going to need, that you can choose the right package that will be less expensive for you. And I want to take a page out of shared decision-making for medical care in terms of one of the things that we talk about is eliciting values and preferences. And that, while we need to reduce the cognitive load and simplify things, what we are at risk of losing is what's most important to the person who's making that selection. And we vary in terms of how risk averse we are. We're very in terms of, how much does the language access network matter to me? And so I guess I'd like to try and raise that more to the fore of thinking about in the ways in which we can make this not very good system that we are not dismantling today work better for people.
Yes.
Yep. Well, he said comment, not question, so I took my liberties.
So, we're all set. Thank you very much. This is really a terrific panel, both the discussions and the questions from the audience. Let me just say that we have lunch at the moment. The speakers and the roundtable members, lunch will be convened in the members' room for a working lunch. And for others, the public, etc., there's a cafeteria on the lower level of the building. We will begin this afternoon at 1:10. Thank you very much.